Hi, we're going to talk a little bit about respiratory ventilatory failure and shunt. So ventilatory failure is a CO2 production that exceeds the ability for the lungs to remove the CO2. And the result is CO2 retention and acidosis. The causes of ventilatory failure are hypoventilation, VQ mismatch, intrapulmonary shunting, and diffusion defects. So let's take a look at that because we had a little question about what is this VQ mismatch? What is this going on? Well, let's look at it. First of all, hypoventilation can come from a number of sources. Somebody can have a spinal cord injury that prohibits them from breathing, and as well as neuromuscular disorders or taking sedatives. You could have severe airway obstruction that prevents you from being able to ventilate, and you can have central sleep apnea. The bottom line is that you're going to end up with a reduced minute volume, and that reduced minute volume, and that's alveolar minute volume, and that reduced minute volume causes hypercapnia. So here's our VQ mismatching. So, okay, let's look at this. V is for ventilation and Q is for perfusion. So as long as the lungs are ventilating and you have blood flow going to them, then they're perfusing. So remember we say it two different ways. You can have ventilation with no perfusion, and that would be dead space, right? Because that's what happens in our trachea. Because we have air in our trachea when we breathe, but it's not doesn't participate in gas exchange. So therefore we consider that it has no perfusion to it. And the disease that we know that can cause this is a pulmonary embolus, right? Because it's blocking the blood flow going to the alveoli. So we have ventilation again in the alveoli, but no flow. So that's an example of a VQ mismatch where there is ventilation, but there isn't perfusion. Then we have what is called shunting. And we call it shunting because you're having the ventilation is reduced. So now these are lung errors. So in regards to the pulmonary system, we consider the true definition would be no ventilation, but there is perfusion. So no ventilation, but there is perfusion. So let's think about that. So no ventilation, but there is perfusion. That's atelectasis, that's pneumonia. And so we quantify it by calling it a shunt because we can calculate how much of that blood is not getting oxygen. And that's where the shunt comes in. That's where that whole shunt fraction comes in, is how much are we missing here? How much damage is there? Taking into account the ventilation and the perfusion and the fact that they are mismatched. Now, most of the time, when you talk about a VQ mismatch, you can be either talking about dead space or shunting. Okay? So typically, when somebody says or when they refer to a VQ mismatch, it just means there's something going on in the lungs. So either there's ventilation with no perfusion or there's perfusion with no ventilation. That's all that term means. And a lot of times in your textbook, for instance, it refers to if it's mild disease, then it's a VQ mismatch. When it becomes a more severe disease, then they refer to it as shunting. So you can also see the terms used that way. So a more mild disease would be just the VQ mismatch, whereas the shunting would be more massive. And maybe that's where the confusion comes in, is because they are both shunting is a form of VQ mismatching, as well as dead space ventilation is a form of VQ mismatching. So I hope that helps a little bit. So they are both VQ mismatches, but just a small VQ mismatch, that's what we call it, a VQ mismatch. And your book classifies it that way, that depending on your AA gradient, that's just considered a VQ mismatch. But when it gets to be severe, then we call it a shunt. So you can think of it in terms of that as well. But here is the actual shunt values, that when we calculate these shunts, the normal physiologic shunt should be less than 10. We'll give you up to 10 because, we have 5 to 6% of our cardiac output that's feeding our bronchial tubes and lungs, that's going to return to our right atrium without getting any, or our left atrium without going to the lungs for ventilation. So we have a built-in shunt. Then this 10 to 19 is considered mild, and 20 to 29 is moderate, and greater than or equal to 30 is the critical number. That is critical. That's where you're going to intervene with mechanical ventilation. So let's look now at impaired diffusion, which is the other problem that's creating these shunts, is that the gas is not getting across into the capillary bed. So you can have various types of diffusion deficits. If you notice that you can actually have a low alveolar PO2, that's what this is referring to. And that happens when you're in high altitude, or because a low barometric pressure, remember this is calculated with that 760, right? At room, at atmosphere, 1 atmosphere. But high altitude patients places don't start with 760. They start with something lower than that, depending on how high up you are. The considerations for traveling in an aircraft that's only been pressurized to 10,000 feet, that the PO2s are going to be lower, and you may have to adjust that. The other person that is at risk here is the fire combustion, because they have taken in carbon monoxide too. So that the result is also hypoxia. Now, the other thing that can happen to you to cause a VQ mismatch or shunt is that you can lose surface area. If you lose surface area, now this is the classic disease that loses surface area is emphysema, but also pulmonary fibrosis, because they get scarred areas that can't transfer, and they also can get blebs. And this thickness of the membrane would also be our pulmonary fibrosis, as well as the edema or retained secretions. Now, these people can't transfer gas because there's too much secretions and fibrosis and fluid in the way, and so the gas can't transfer due to thickness of membranes. And you can also have an insufficient time for gas to diffuse, and that would be seen with somebody that has bad tachycardia, high heart rates, because the blood's going too fast through there. So people that are have dysfunctional rhythms that result in tachycardia will, the blood cells are going by there too fast, and there's just not enough time. So these are all the things that cause defects in your ability to get oxygen to your tissues, right? That's it. That's what we're talking here. Can we get oxygen into our bloodstream? Well, not if it's not there to begin with, and not if you don't have enough surface area, and not if your membrane is too thick, and not if you don't have enough time to get it there. So these are all the measurements, or the typical measurements that are used to quantify the severity of somebody's hypoxemia. So you can see up here we have the PF ratio, and we've talked about that a lot. The PF ratio normal should be this greater than 350 to 380. And the abnormal signs, see here, when it's little here, we've got, look, a little VQ mismatch, mild ARDS. So if it's 200 to 300, then we're just going to say that you have a little VQ mismatch, okay? So this is mild disease. Now we get up here and we've got shunting. So there you have a little differentiation between your VQ mismatch and shunting. The 100 to 200, some shunting. And so, but don't get confused by that. It just means a more severe lung disease. So there's more problems with ventilation. And here we have a lot of problems. Ventilation, and this is severe shunting. So a lot of blood is not getting oxygenated. So I'm going to pick back up here in a minute. I'm out of time, and so I'll pick this up on part 2.